Hi guys, good evening. I hope everybody is doing well. I hope I'm audible, I'm visible. Good evening, good evening. Can you all see me? Can you all hear me? A quick feedback. Can you all see me? Can you all hear me? A quick feedback. Now, anyhow, today's topic is going to be very, very interesting. We are going to talk about peptic ulcer disease. All right, so today's topic is about peptic ulcer disease. Right. So when we say the word peptic ulcer disease, let's try to decode each individual word. When I say the word peptic, right, the word peptic basically means pepsin. So initially, when peptic ulcer disease was coined, they thought it is because of excessive pepsin secretion, but it is not, right? So basically, peptic word is a misnomer, right? They accepted it. They said, no, it is not because of hyperpepsin or excessive pepsin secretion. It is just a misnomer. So please don't feel bad about it. Then the word introduced was ulcer. Now we all know ulcer is nothing but breach in continuity. It is breach in continuity of epithelium or mucous membrane. It is breach in the continuity of epithelium or mucous membrane with microscopic death of tissue. With the microscopic death of tissue is what we call it as ulcer. So now you have two words. One is a pepsin, another is ulcer. We know how what is an ulcer is defined as. Now the pepsin is a misnomer. So what exactly it is going to be with respect to the peptic ulcer disease, right? Now we all understand for a fact the peptic ulcer disease, even though it's a misnomer, currently, if I say what is the true reason for the peptic ulcer disease is because of excessive hydrochloric acid concentration. It is increase in the concentration of the hydrochloric acid. There's increase in the concentration of hydrochloric acid. Along with that, there is mucous membrane inflammation. There is mucous membrane inflammation that is associated with it, right? So currently the word peptic ulcer disease basically is because of excess amount of hydrochloric acid with association with the inflammation of the mucous membrane. Together it is what we call as peptic ulcer disease, right? Now before we move down, couple of important points about the peptic ulcer disease. They will ask you what is the overall most common site, the most common site for peptic ulcer disease. Now, one thing that you need to understand that it is usually seen in gastric type of mucosa, right? So peptic ulcer disease are specifically found in gastric type of mucosa. It is seen in a gastric type of mucosa. So the overall most common site is going to be the first part of the duodenum. D1, that is the first part of the duodenum, is going to be the most common site. Now, if I ask you what is the most common site within the stomach, the most common site within stomach, within stomach for peptic ulcer disease, it is going to be lesser curvature, and within the lesser curvature, It is more commonly found in angularis incisura. So what is angularis incisura is, if you look at, this is the esophagus, this happens to be stomach, that's the greater curvature, this is the lesser curvature. Now on the lesser curvature, you will notice specifically where the lesser curvature is going in and then coming out. This is the site which is called as angularis incisura. So if I say the overall most common site, the overall most common site for the peptic ulcer disease is going to be the angularis incisura of the stomach. It is the angularis incisura of the stomach, right? Now, in general, if I have to tell you what are the sites where you will actually come across peptic ulcer disease. Now, as I just mentioned, that it is seen in gastric type of mucosa. Now, where do you see this peptic ulcer disease? So as I told you, it is seen in gastric type of mucosa. It is seen in the first part of the duodenum. It is seen in the stomach. It is seen in the stomach. It is seen in the lower 1/3 of the esophagus, where you have a gastric type of mucosa. And the last one, it is seen in Meckel's diverticulum. So when I go ahead with Meckel's diverticulum, I'll dig a little bit deeper into it, but Meckel's diverticulum follows something called rule of two, in that you have gastric type of mucosa is also available. Okay. Now, these are the usual sites, and if I have to say what is the overall most common site, remember D1 happens to be the overall most common site for peptic ulcer disease. Now, see, I can attribute a lot of risk factors to peptic ulcer disease, but I would want to highlight about one particular component, one particular factor in terms of risk factors, right? So the risk factors in terms of the peptic ulcer disease, especially when you're talking about the gastric ulcers, we have a culprit which is called as the H. pylori bacteria. It is an H. pylori bacteria. In fact, this happens to be the overall most common cause for the peptic ulcer disease. This happens to be the most common cause for the peptic ulcer disease, right? Now, you need to understand how peptic ulcer or the H. pylori contributes to the development of peptic ulcer disease. Now, H. pylori bacteria is a urease producing bacteria. This urease producing bacteria but basically converts the urea into ammonia. It converts the urea into ammonia, right? Now, urease is water soluble. It will excrete out of the body. Ammonia is lipid soluble. It is going to retain in the body. And the problem with ammonia is it is a strong alkali. It is going to be a strong alkali, right? Now, what is the effect of ammonia in the GI mucosa that you need to understand? I'll talk about the stomach first, and then we will go and talk about duodenum. So if you take this as the representation of the stomach. Now this angularis incisura is actually present at the antrum of the stomach, right? If you see very carefully, this happens to be your gastroesophageal junction. This would be the cardia of the stomach. This happens to be the fundus. This happens to be the body. This happens to be the antrum. This happens to be the pylorus of the stomach. As I told you, so cardia is there, fundus is there, body is there, antrum is here, and the pylorus is here. Now, as I told you, the most common site is the angularis incisura, which falls into the antrum of the stomach, right? Somebody gave me an answer as antrum, so I'm not going to, reject that answer. It is going to be in the context of that. Okay. Now, what happens in this whole context? Now, as I told you, if you remember, you go back to our physiology class, I told you that there are these cells which are present in the antrum of the stomach, which are called as the G cells. The maximum concentration of the G cells are in the antrum. So what this ammonia does is this ammonia goes and stimulates. So all these are your G cells. So this ammonia that is produced, this is going to go and stimulate the G cells, right? All this ammonia that is produced is going to stimulate the G cells. Now, once the G cells are stimulated, now this excessive stimulation of G cells will produce more amount of gastrin. Now, we know that the gastrin, if it is produced, it is going to stimulate the parietal cells, and when it is going to stimulate the parietal cells, it will cause excessive production of hydrochloric acid, and this excessive production of hydrochloric acid is there in the stomach, right? Now here's an interesting thing. One, there is an excessive stimulation of parietal cell which is now producing hydrochloric acid. Second, because the ammonia is such a strong alkali, it will try to neutralize the acid, and this area where the H. pylori is now going to proliferate. See, when the alkali is produced, obviously it is going to react with acid, and when alkaline acid reacts, it is going to form base. So that environment will become neutralized. Now, when that environment is neutralized, what is going to happen? All these bacteria which are present in the H. pylori will become submucosal, and now it will start to proliferate. So one, there is increase in hydrochloric acid. This strong alkali which is going to be produced is neutralizing the acid and also resulting in inflammatory response. It is going to result in inflammatory response in the mucosa of the stomach. In the mucosa of the stomach. Okay. Now, this strong inflammatory response which is present in the mucosa of the stomach combined with excessive acid secretion secondary to hypergastrinemia is the villain of our story, right? Did you all understand? So far so good. Quick feedback. So far so good. Quick feedback. Clear? Okay. Now this inflammatory response of the mucosa, due to this, these are basically secondary to the enzymes produced by H. pylori. Can anybody give me two major enzymes, or I can say the two major components which are produced by H. pylori? Quick feedback. Or we say enzymes, or I can say the cytotoxins basically. Either you say enzymes or you call it as cytotoxin. Either you call it as an enzyme or you call it as a cytotoxin. What are those two cytotoxins which are produced? Number one is the CAG-A, another one is your VAC-A. Now, these are the enzymes which are responsible for gastritis, which are responsible for causing chronic gastritis, chronic irritation. It can result in erosive gastritis. It can result in peptic ulcer disease. It can also cause gastric carcinoma. So the villain in this story is CAG-A and VAC-A. So let's understand the whole concept again, right? So what is going to happen is when the H. pylori enters into the stomach, it produces an enzyme which is called as a urease enzyme. It converts the urea into ammonia. Ammonia is a strong alkali. Now this strong alkali has two things. One, it is going to stimulate the G cells. I'm just going to add it here. One, it is going to stimulate the G cells of the stomach. Another one, it results in strong inflammatory response. Now when it stimulates the G cells, it is going to cause excessive amount of gastrin, and this is what we call it as hypergastrinemia. This is what we call it as hypergastrinemia. Now, hypergastrinemia combined with the inflammatory response within the GI mucosa, inflammation will cause friability of the cells. It will cause damage in the mucosal membrane, and that is associated with the enzymes produced by H. pylori, which is cytotoxic, that is CAG-A and VAC-A, which is now going to cause the erosion, hence the ulceration within the stomach. Now, if you look at the duodenal ulcers per se, if I give you, so this was the pathophysiology. If I have to supplement this, this was the pathophysiology for the gastric ulcers. This is the pathophysiology that is going to take place in the gastric ulcer. Now, what is the story for the duodenal ulcers? What is the story for your duodenal ulcers? So when you look at the story of the duodenal ulcer, now duodenal ulcer do not have gastric type of mucosa. So how it is going to happen? Now you need to understand that this happens to be the esophagus, this happens to be stomach, and let's say this happens to be the duodenum. So let's say this is the pyloric sphincter that is present. This is the pyloric sphincter that is going to be present here, right? Now, when you look at the entire story, as I told you, because of excessive stimulation of G cells, the parietal cells was stimulated, and that parietal cell stimulation caused excessive amount of hydrochloric acid, right? So what is going to happen is this excessive amount of hydrochloric acid is now going to pass through the duodenum. Now, when it goes to the duodenum, we all know duodenum is going to have its own cells which are called as duodenocytes, which are sensitive to acid. Now, these duodenocytes are sensitive to acid. So, every time it is going to fall onto the duodenocytes or the duodenal cells or duodenal mucosa, it is going to burn off, right? Body says, I cannot let this happen. I have to come up with adaptability. So, what it does is it will now start to transform into gastric type of mucosa. So there is a metaplasia that is occurring. So within the duodenum, there's a metaplasia which is going to convert the duodenal cells into gastric type of cells. But along with that, they also get this special features that they produce with the mucin secreting ability. Okay. So there's a mucin secreting ability which is going to be in this duodenal cells. Okay. So this metaplasia of the duodenal cells, which is transforming into gastric type of mucosa, allows the H. pylori, let's say this is our H. pylori, allows the H. pylori bacteria to come and enjoy and do party here. And once the H. pylori comes here, because it is also having a gastric type of mucosa, it will also produce the same hydrochloric acid. It will have the same effect as urease enzyme. It will convert urea into ammonia. Again, same inflammation, same erosion, and same ulcers, right? So the whole concept in duodenal ulcers is because of this. So what is going to happen? There is hypergastrinemia. There is hypergastrinemia in response. There is hypergastrinemia in response in response to the ammonia produced in the H. pylori. Now this hypergastrinemia is going to stimulate the parietal cells. It is going to stimulate the parietal cells in the duodenum. When the parietal cells in the duodenum is stimulated, it will produce excessive amount of hydrochloric acid. Now this excessive amount of hydrochloric acid, it is now going to flow into duodenum. It is going to flow into duodenum, where it will cause duodenocyte damage. Now this excessive amount of acid in the duodenum forces the duodenum to undergo metaplasia, right? So this hydrochloric acid into duodenum converts the duodenal mucosa. It converts the duodenal mucosa into gastric type of mucosa. Into gastric type of mucosa. And this gastric type of mucosa is what we call it as the metaplasia. Now, once it forms into a gastric type of mucosa, it will produce hydrochloric acid, allows the peptic ulcer disease to be formed in response to H. pylori. So once there's a gastric type of mucosa, you will see there will be an H. pylori invasion. An invasion of H. pylori will result in development of peptic ulcer disease. Will result in the development of peptic ulcer disease. And that's the story of your duodenal ulcer. So you have the story of both your gastric ulcers as well as your duodenal ulcers. Is everybody clear with this? A quick feedback, please. Is everyone clear with this? A quick feedback. All right, chalo. So let's moving on. We'll do a small comparative factors, but I'll complete the entire risk factors while I said. So if I have to list the entire risk factors associated with the peptic ulcer disease. So for duodenal ulcers, it is usually going to be H. pylori, right? Otherwise, when you take what are the other risk factors apart from H. pylori's infestation, it is associated with smoking. It is associated with usage of NSAIDs. It is associated with usage of steroids. It is secondary to stress also, which are called as stress ulcers. I hope everybody knows that if it is secondary to burns, this is what we call it as the curling ulcer. If it is secondary to a head injury, then it is a Cushing ulcer. Then it's going to be a Cushing ulcer. So it's an H. pylori, there's a smoking, it is associated with NSAIDs, steroids, stress ulcers, and then you have an endocrine cause. So in an endocrine cause, it is associated with gastrinoma, that is gastrin producing tumors. Now this gastrinoma or a gastrin producing tumors, this is also called as the Zollinger-Ellison syndrome, right? It is also associated with Cushing syndrome. And this is also associated with hyperparathyroidism. Also associated with hyperparathyroidism. So gastrinoma is a gastrin producing tumor. It's a neuroendocrine tumor. It's a neuroendocrine tumor, and this is basically a gastrin producing tumor. This is basically a gastrin producing tumor. This is a gastrin producing tumor. Clear? So that's the basic objective in terms of risk factors associated with the peptic ulcer disease. Now, I would like to have a very clear-cut demarcation about the gastric ulcers and the duodenal ulcers, and then we'll try to summarize there itself. Okay? So when you have a comparative degree or the comparison between the two common peptic ulcers, one will be talking about the duodenal ulcer. Another one is going to be your gastric ulcer. One you have the duodenal ulcer, another one it is going to be the gastric ulcer. Now the things that we're going to compare upon, I'll be comparing upon the acid secretion, or I can say the environment per se, environment of the ulcer, status of pain. We'll talk about the appetite. We'll talk about the appetite. Now, in terms of, I would say symptoms that are going to be present. Okay, we'll talk about the acids environment. We'll talk about the pain. We'll talk about how the appetite is going to be present across here. We'll talk about the status of weight in these patients. probability of obstruction, upper GI bleed, as well as perforation, right? So you look at the status of both the ulcers, no? In general, when we talk about it, duodenal ulcers, in which environment do you think it is formed? Is it going to be a hyperacidic or a hypoacidic environment? Okay, hyper या hypo. Now, when you talk about in general, you'll say duodenal ulcer should be formed in hypoacidic because the normal component or a normal way or the normal site of the duodenum is going to be a I mean, when you talk about stomach, the pH of the stomach. All right. Thank you, Pratik. Thank you so much, guys. Okay. So here's the concept here. So when you talk about the duodenal ulcers in general, if you look at the pH of the stomach, it is 1.5 to 2, whereas duodenum is somewhere between 5.5 to 6, 6.5, right? So when compared to stomach, the duodenal ulcers are usually in a less acidic state. But if you look at our pathophysiology, I've clearly told you that the acid secretion is going to increase in the duodenum. So the pH of 5.5, because the excess acid will drop down and the ulcer will develop. So in this context, what is the environment of the ulcer in the duodenum during which is formed, or the time at which it is formed? It is going to be excessive, and this is going to be in a hyperacidic environment. It is going to be your hyperacidic environment. Gastric ulcers, on the other hand, they will be formed in the gastric mucosa. Now, the pH of the gastric mucosa, when you talk about it, is 1.5 to 2. Right. So if the ulcers are formed in this pH, we say it's a normal pH of the stomach. Right. You can't say hyper or hypo because we're comparing it to its previous state. No. On the other hand, if the ulcers are formed, it will erode the gastric mucosa, and erosion of the gastric mucosa will cause damage in the parietal cells or the gastrin producing cells or G cells, which will cause decrease in acid production. So hence the ulcers will be formed in less acid producing environment, that could be hypo. Okay. So we say in gastric ulcers, either it will be produced in a normoacidic environment. Worst case scenario, it will be produced in hypoacidic. It will be produced in a hypoacidic environment, right? Hi Chirag, good evening. Now, see, the pain is going to be present in both duodenal ulcer as well as gastric ulcer, but the intensity of the pain in gastric ulcers is much, much more high. Another very important thing is whenever the patient is going to consume the food from the stomach to duodenum, that is your gastric emptying time is 2 to 3 hours. So patient will experience pain after 2 to 3 hours of consuming food. They will experience the pain So talk about the pain. Right. So talk about the pain. You will notice the pain in the duodenal ulcers will be seen after 2 to 3 hours of consuming the food. Now, because the gastric emptying time is 2 to 3, whereas in the stomach ulcers or in the gastric ulcers, from the mouth to stomach, the transit time is very less. It is going to be as early, like the minute the patient swallows, it hits the ulcer, erodes the ulcer, and causes pain. So it is going to be an immediate food pain. This is going to be an immediate food pain. Now, here's the very interesting thing. The intensity of the pain in duodenal ulcers is less and it takes after 2 to 3 hours. So obviously patient might misinterpret this hunger pain. To compensate for that hunger pain, he'll say, I have to eat more. So the appetite here increases. On the other hand, gastric ulcer, with every single bite the patient swallows, it hits the gastric ulcer, erodes the gastric ulcer, hence causes excessive amount of pain. So here the appetite is going to fall. If there is increase in appetite, obviously there will be weight gain, and with a decrease in appetite, there will be weight loss. So gastric ulcer patients will be thin and lean, whereas the duodenal ulcers are going to be obese because they're going to eat more, right? Obstruction, when you talk about it in terms of where you have strictures. Now, it can be seen in both conditions. I'm not denying the fact that obstruction will be present or may not be present. So when you talk about the obstruction per se, is more common or I can say the possibility of obstruction is more common in duodenal ulcers when compared to gastric ulcers. So in terms of bleeding, when you talk about it, which ulcers do they bleed more, right? Now remember, in general, when you talk about it, the bleeding's overall phenomena is more common in gastric ulcer, is more common when compared to duodenal ulcers. When compared to duodenal ulcers. Perforation is more common in duodenal ulcer when compared to gastric ulcers. So we say the duodenal ulcer perforates and the gastric ulcer bleeds. Divyanshu Gupta, once you crack NEET, yes, you will come to us and then we will study together. Okay, until then, please concentrate. All the best and have best of luck. Ciao. Okay. So these are with respect to this. Okay. Now, with respect to the socio-economic status. Now, out of these two, if I have to tell you in Hindi, इनमें से कौन सा अल्सर अमीरों का अल्सर है, कौन सा गरीबों का अल्सर है? आउट ऑफ द डिओड्रल एंड द गैस्ट्रिक अल्सर्स, एक अल्सर अमीरों का है, दूसरा जो है वो गरीबों का है. तो कौन सा अल्सर अमीरों का है, कौन सा अल्सर गरीबों का है? अमीरों का कौन सा, गरीबों का कौन सा? Now see, you need to understand when we talk about in the context of presentation, H. pylori's manifestation is more with gastric ulcers when compared to duodenal ulcers. And obviously अगर आप ऐसे बोलोगे ना, सीधे सीधे बताता हूँ, खाना खाने के लिए पैसे लगते हैं और पैसे अमीरों के पास होता है. ठीक है, तो डिओड्रल अल्सर वाला ज्यादा खा रहा है तो अमीर हो गया, और गैस्ट्रिक अल्सर वाला कम खा रहा है तो गरीब हो गया. तो वी से दी सोशियो इकोनॉमिक स्टेटस फॉर डिओड्रल अल्सर्स इज गोइंग टू बी हाई. ये अमीरों का अल्सर है और गरीबों का लो. और जैसे हर जगह होता है यहाँ पे भी वही है, द प्रोबेबिलिटी ऑफ मैलिग्नेंसी, दैट इज इनमें से कौन सा कैंसरस हो सकता है. डिओड्रल अल्सर्स कभी भी नहीं होते हैं कैंसरस, लेकिन गैस्ट्रिक अल्सर्स होते हैं यूजुअली कैंसरस. सो दैट इज व्हाई द नीड फॉर बायोप्सी इज वेरी वेरी इंपॉर्टेंट. सो अगर आप मुझसे पूछोगे व्हाट इज द इन्वेस्टिगेशन ऑफ चॉइस, अगर डिओड्रल अल्सर है तो मैं बोलूंगा भैया सिर्फ अपर जी एंडोस्कोपी करो, देखो वापस आओ. लेकिन अगर वही आपका गैस्ट्रिक अल्सर है, अपर जी एंडोस्कोपी विथ बायोप्सी इज मस्ट. With biopsy is must. So when you look at these ulcers, no. So you can see this is how a duodenal ulcer would look like. And this is how a gastric ulcer or a antral ulcer would look like. Look at the bleed that is present, right? So this is with respect to your both duodenal as well as gastric ulcers. Clear? Clear, guys? So that's the basic difference between your two common ulcers, that is your peptic ulcers, as well as that is your gastric and duodenal ulcers, right? See, I don't want to break the continuity because I want to talk about the investigation and management in one single go, and whatever time that we have at our disposal today is not going to suffice. So tomorrow we'll talk about the investigation and the management of peptic ulcer disease. That is going to be absolutely important, right? So today what did we learn about is we learned about what is a peptic ulcer, right? What is the pathophysiology behind a peptic ulcer when it is formed in our stomach and when it is formed in the duodenum. A very very important concept. Once you're done with that, we spoke about the risk factors and the basic difference between your duodenal and the gastric ulcers. Now as we go towards it, we'll talk about the clinical manifestations, investigations, management as one single concept. Okay. So until then, thank you so much for joining today. We'll resume back tomorrow at 9 o'clock. Tomorrow I'll be discussing about the clinical features, investigation and the management of peptic ulcer disease. All right. Thank you so much for joining today. See you tomorrow at the same time. Bye bye. So for NEET PG next year, should we do BLS or main notes? Beta Pratik, for if you're targeting next year NEET PG, right? I would recommend you to concentrate whatever videos that we have on our app, that is going to be purely for NEET PG. But if you are in a third final year, then BLS is going to be single most important source for surgery. ठीक है प्रतीक, अगर आप नेक्स्ट ईयर एग्जाम दे रहे हो तो बेटा स्विच बैक टू आवर ऐप वाले वीडियोस. दे आर अमेजिंग. वी हैव डन इट in a very precise manner and to the point and what is required for the exam. Just go and look at it. ठीक है. Chalo. Have a great time. Thank you so much. Good night. Bye bye.